All right, so let's start by biliary colic, the very first disorder for biliary tree, and again a very simplified understanding of what's happening here. If this is the liver, right, this is the right hepatic duct, left hepatic duct, then we have the first union here. This is right hepatic duct, left hepatic duct, and then we have this common hepatic duct, no rocket science here. All right, and then this is the gallbladder sitting over here. This is the cyst, this is the fundus, and then this is the neck, so we go cystic duct. And then these two kind of have the second union, and second union is called common bile duct. Common because it comes from common hepatic duct, bile because it's also a union of cystic duct, right? And then both of them, they meet the pancreas, and then pancreas with all of its juices has the pancreatic duct, and they form the last union here in our simplified diagram, which is called common hepato, because everything from the liver and the gallbladder, pancreatic duct, right? And then this duct just goes here and it drains to the duodenum. It secretes to the duodenum, right, for the fat digestion. So what happens in the biliary colic is sometimes there is a small stone can be formed here, right? And this small stone, it will cause this small stone can basically kind of like travel to the neck. So this is the fundus, like a very simplified diagram of the gallbladder. This is the fundus of the gallbladder. This is the body, and then this is the duct, right? So this small stone can basically move to the duct and get stuck here, and then come back to the body, and then go again back to the neck, and then come back to the body. It's kind of like a back and forth movement of the stone from the body to the duct, from the duct to the body, whenever it's squeezed, because the main point of the gallbladder is that it squeezes when we eat, especially when we eat heavy fatty meals. It's kind of like squeeze to secrete the bile, right? The bile juices. So if there is a stone, this stone will also be squeezed, and guess what? It's going to be stuck here. It's going to be stuck right here in the duct, right? And when it's going to be stuck here, and then if it's not big enough, it will not be stuck forever. So it will go back there, right? It will go back to the body, and then back and forth, back and forth. So what happens here is that the patient, if we draw a patient here, this is our patient who is in pain, unfortunately. So this patient would have right upper quadrant, so the pain would be here, because there is the liver. Liver is in the abdomen, right upper quadrant, and there is a small gallbladder. So this transient gallstone impaction will lead to intermittent right upper quadrant pain. This transient gallstone impaction at the cystic duct will basically lead to right upper quadrant intermittent pain, right? And it also can be here as well, the pain, not the epigastric. Gallbladder is right here, but the pain can also be epigastric. So the patient would have right upper quadrant intermittent epigastric, or right upper quadrant pain. Right upper quadrant is more classic. Exam is generally benign, and it would be associated with nausea. Patient will come and say they are not able to eat because they are nauseated, sometimes vomiting, and it's almost always associated with fatty, heavy meals. We call it postprandial epigastric pain. It's more classic in acute cholecystitis. When this patient comes to the ER, we ask for labs. Most of the cases, the labs will be unremarkable, i.e. we would not necessarily have high total bilirubin or high white blood cells, because it's kind of like a benign condition where you have the stone just coming in and out from the gallbladder. So you'd have a normal labs, generally speaking. But if we did a bedside ultrasound, most of the time you're gonna find the gallstones. You're gonna find gallstones in the gallbladder itself. You could find some thickening of the gallbladder wall, but generally speaking, the gallstones will be there. How do we treat these patients? We treat them by pain and nausea control. You can give them Tylenol, Motrin. You can give them, or whatever pain medication appropriate for the patient. You can give them Zofran or Raglan for their nausea. And then majority of these patients would discharge with outpatient cholecystectomy. What does that mean? Outpatient means we don't have to admit them inpatient. And coli, the word coli in Greek, it means bile. Cyst means the cyst, and then ectomy means remove it. It means that they have to follow up with a surgeon. So to have an elective cholecystectomy, it's not necessarily something urgent. We don't have to keep them in the hospital. We don't have to do an inpatient. We don't have to do an inpatient admission. They can just follow up with a surgeon and do an outpatient cholecystectomy according to their case. And of course, do not forget to mention to your patient the low-fat diet. It's very important for them to have low-fat diet, because this is the whole point of, this is why they have these symptoms, because of the high fat diet they are having. This is likely a very benign condition in compared to another. Next, this is likely a very benign condition. Speaking of biliary tree problems in comparison with others, which we're going to talk about next, acute cholecystitis.